Oh, excellent, excellent. Okay, so absolutely, first of all, it is totally a privilege for me. So thank you very much, guys, for inviting me. This is fantastic, and this is such a great venue here that I'm speechless. So thank you very much for the opportunity. Now, what I would like to talk about and what I would like to introduce you guys is a trial that was designed for pancreatic cancer patients that have locally advanced unresectable pancreatic cancer. And this trial is about comparison of carbon ion and IMRT, in other words, of photon therapy. So that's this whole show that I'm going to show you about is about this. The carbon, I mean the cancer, the trial name was Cipher, and it stands for carbon ion versus conventional photon radiation therapy for locally advanced unresectable pancreatic cancer. Now, first is the motivation. Why in the United States, in UT Southwestern Medical Center in Texas, we're designing a comparison of a carbon ion with photon therapy? And the answer is in this map, because the United States has 0 carbon ion centers, and the world has a bunch of carbon ion centers. And we wanted to build also a carbon ion center or a heavy ion center in the United States. And we thought that we better try and show to the people in the US that it makes sense, that it has benefits, and that it's an awesome thing to build. So motivation 1. Motivation 2 was this one here, that our Japanese colleagues had a fantastic run, and in a non-randomized fashion, they showed that carbon ion has a huge advantage for pancreatic cancer patients, namely for the locally advanced unresectable pancreatic cancer patients. What they showed, again, in a non-randomized fashion, that if you deliver 55.2 gray equivalent with carbon ion, the 2-year overall survival was about or more than 60%, while the conventional method, you know, with photons and chemotherapy, it's very dismal. It's about 20%. This alone is a huge motivation factor to actually try this out. Now, what we wanted to do is to do this in a randomized fashion, because we thought that if we generate a randomized clinical trial, even the largest skeptics would accept it. So that's our 2 motivations that we tried to do this. Now, what is it that we were always challenged? Randomization. So the Japanese colleagues, you know, they had a huge success, as I mentioned, with carbon ion irradiation of pancreatic cancer. And anytime we wanted to offer, you know, like, let's do a randomized trial, you know, then anytime we did this, what was the answer? Arnold, why do you want to do this? We know it's better. We know it works. Look, you know, why do you need to do an randomized trial if you jump out from an airplane with or without a parachute? Isn't it clear? So of course we laugh it out, etc., etc. But I just wanted to show you that there is, it's a non-trivial thing, you know, to actually generate a randomized clinical trial that would compare carbon ion with photon therapy, because of the historical thinkings and how, you know, the data was collected so far. So that's one thing. Now, what it took. So it took a lot of diplomacy. So it took a lot of meetings, you know, between our Japanese colleagues and between the United States, between us, you know, here's Dr. Choi, you know, our chairman, used to be former chairman, that we visited every single person in Japan. We tried to explain them why the Western world needs a randomized clinical trial. And we did it once, we did twice, we did 5 times, we did 10 times, we did 50 times, we did 100 times. And at some point, we came to this. And this was the final ultimatum, you know, which actually led to the handshake. So at the end, we received the handshake and Cipher was born. What is Cipher? It's a carbon ion system manufacturer supported trial. I'll tell you in a second which one. It's a phase 3 randomized international clinical trial that compares carbon ion therapy with IMRT. Again, after all this diplomacy and about this slide, finally, we had the handshake, and we were able to construct the Cipher. Now, what is Cipher? Answer: Cipher is a phase 3 randomized clinical trial that compares carbon ion therapy with the dose of 55.2 Gray equivalent in 12 fractions with IMRT, and IMRT is about 50.4 to 56 Gray in 28 fractions. So both, would receive concurrent chemotherapy with 4 cycles of systematic chemotherapy. But the very, very details of, which chemo and so, I don't think, it's relevant for this group here. What I wanted to show you guys is the big picture of how we did this and what we did this. So patient would receive 4 cycles of gemcitabine or FOLFIRINOX, either 2 cycles before and 2 cycles after carbon ion therapy, or 4 cycles after. Carbon ion therapy would be delivered with concurrent gemcitabine, IMRT with gemcitabine or capecitabine. So in other words, in general, the important thing is that it's not radiation only, it's radiation with carbon ion. It's radiation with chemotherapy, because that was the standard. That's how the Japanese colleagues, they achieved this incredible, 60% of survival, overall survival for this locally advanced unresectable pancreatic cancer in 2 years. So we wanted to really mimic that in a randomized fashion. Which patients were eligible for the Cipher? It was a locally advanced unresectable pancreatic cancer. The distance between the tumor and the duodenum, should be no less than 3 millimeters. The patients cannot be extremely huge. The metal extent in the pancreas and bile duct was forbidden. And these patients obviously had to be able to travel to a foreign country on a short notice. And at most, 2 cycles of chemotherapy could be delivered at an outside institution, and neoadjuvant chemotherapy delivered, if there was delivered, it had to be like a no progression after 2 cycles. Here's the schema 1. This is the first schema for the Cipher. It was a randomization 2-to-1, arm 1 and arm B. Arm 1 was carbon ion therapy that would deliver 55.2 Gray in 12 fractions. And note here, I have 55.2 Gray equivalent or 57.6 Gray equivalent. And the reason is because I'll show you in a second. The reason is because where would these patients be treated with which biological model calculated? So one was the Japanese one and one was the European one. And the researchers, in CNAO and in Japan in NIRS, they showed that for the same physical dose, the 2 different biological models would actually correspond to slightly different doses. Hence, this is how we took care of that. And then the arm B would be IMRT with plus chemotherapy. And then we would follow the patients for overall survival and progression-free survival. So that would be schema 1. And then in order to potentially increase and catch other patients, because it's very, very difficult to catch patients, that would have no prior therapy before we would able to actually see them. Usually the medical oncologists, they catch these patients and they start, chemotherapy. So in order to increase our potential for enrollment, we also had a schema B where some chemotherapy ahead was allowed, and then the rest was identical. Okay, so what were the participant centers? So patient recruitment, or the big picture was the patient recruitment would occur in Japan, would occur in Italy, and would occur at United States. So in Japan, we had the NIRS/QST center participating, and Gunma. In Italy, it was CNAO and the IEO centers. And then in the United States, it was UT Southwestern. Internet, and then more sites, of course, we were discussing, and I'll get there when we're talking about the challenges. More sites, I mean, around the world. International traveling patients would receive carbon ion therapy in Japan at the NIRS. And patients that randomized, let's say in the United States, if they got randomized to photons, they'll be treated at UT Southwestern. If they got randomized to carbon ion, they will be flown to Japan for the treatment. And then, after the treatment, they would return back. Japanese patients would receive the carbon ion therapy at NIRS or in Gunma, and the Italian patients, they got randomized to carbon ion, they will be treated in CNAO. If they got randomized to photons, they'll be treated at their own institutions, such as IEO in Milano. The endpoints were obviously the overall survival, because that's what we wanted to mimic. The Japanese colleagues, had this awesome result. And in order to actually prove this big gap between the photon and between the carbon ion therapy results, we only really needed 93 patients with the 2-to-1 randomization. So a total 93 patients to complete was needed. 62 would receive carbon ion therapy, 31 would receive IMRT, and then we would show not even all the way up to 60. We would be happy if if we were able to show that the overall survival, 2-year overall survivor, was increased from 22% to 48%, and we did not even, if we wanted to show 60, potentially we would need even a smaller amount of patients, but we were trying to be conservative, so we designed it for 22 versus 48. And then, so 93 patients would have been needed to complete. We've calculated in the natural dropout rate about 20%. So 110 patients, 110 subjects to be enrolled was actually what was needed we thought to finish 93 patients. The secondary endpoints were progress-free survival, and then cumulative incidences of local regional recurrence and distant failure, quality of life, and the rate of rate of toxicities, the grade 3 to 4 non-hematologic toxicities would have been studied. Quality assurance was super important. So how it was designed was that all contours would be reviewed by the Japanese physicians prior to treatment planning, carbon ion or IMRT, with NIRS contours would be reviewed by the Italian colleagues. So Italian contours reviewed by Japanese and UT Southwestern, and Japanese contours reviewed by Italians and UT Southwestern. All carbon ion plans would be reviewed again by NIRS and the physicians prior to treatment, and the NIRS plans would be reviewed by the CNAO physicians in Italy. All IMRT plans would be reviewed by UT Southwestern physician prior to the treatment. So we had this overarching mixture of treatment of quality assurance that medical doctors care the most about. Credentialing was also very important, because now we're talking international multi-continental sites. So we better ensured, that if somebody says, I delivered 1 gray of those, that it's the same gray, in Japan, in Italy, in UT Southwestern, all over the place. So all sites, would have undergone rigorous credentialing procedure before the enrollment was enabled. The photon sites, we mimicked what we do normally for US-based clinical trials. So the UT Southwestern, we partnered with IROC in Houston and MD Anderson, their quality assurance center. All sites, would get IGRT, IMRT credentialing the same way, absolutely the same way as we credential for other US-based clinical trials, photon-based clinical trials. All sites, will participate in annual dosimetric output audits. Again, this is a standard thing that each year we irradiate the phantom, we submit it to IROC, they read it out, and then, we compare, whether we understand, how we deliver those. And then all sites would demonstrate the Cipher-specific electronic data transfer capabilities, because, this would be around the world, the data exchange. Carbon ion sites what we designed is we took exactly the same credentialing as we do for photons, and then we mimicked it and translated it into the carbon ion world. So all sites, would get IGRT credentialing, and the credentialing body would have been us, UT Southwestern. So we would collect all the data, and then we would be analyzing it, and then we would get out the credentialing letters. All sites demonstrate the planning ability. Again, take phantom or take anonymized CT sets, and then we would contour, and then the planner would demonstrate a capability of generating a treatment plan that is matching the criteria of the Cipher protocol. UT Southwestern would perform the annual dosimetric output checks of all sites, including all the international sites. So that would be, again, like one institution, us making sure that the homogeneity of the dose distribution of the dose output across the sites is existing. All sites would demonstrate the protocol knowledge of assessment. All sites would demonstrate Cipher-specific electronic data transfer, as I mentioned, and then we would perform the biological dose cross-calibration, because the Japanese sites, they express the dose in MKM biological model, and the European sites, they express in LEM biological model. So all this was taken care of, and all this was calculated in. Well, it's easy to say what I just said, but it's really, really hard to do. And here's the list of challenges that I'll go through, and then in a few minutes, I'll tell you like where we stand. So here's the list of challenges. Who's going to fund this? How are we going to do credentialing of these sites? The institutional review boards, they really have to scrutinize what we're trying to do here. So the IRBs at each institution had to take our protocol and then munch on it, and then understand it, and then see, oh, I see, this makes sense, for our patients here. So IRB approval was an absolute must. You can imagine, why. So, and you can imagine what kind of havoc, this means. For example, if you go and you try to open the trial in Korea, and then you would say, what are you trying to do? You're trying to randomize patients, Korean patients, just like American patients. And if a Korean patient gets randomized to carbon ion, you're going to send this patient to Japan to treat? Well, in Korea, we don't have a carbon ion. I'm talking minus a couple of years. We don't have a carbon ion. How can I don't know anything about this. How can I send a Korean patient, to Japan, to get a carbon ion? So you understand, the hesitancy of these countries and how it works. Okay, so then the carbon 12 biological modeling in 3 continents. That's also a headache and a challenge. How to do randomization? Why to do randomization? The Japanese colleagues, they clearly told us it's clearly better. So why do you want to randomize? And then eligibility review. Once you identify a patient, how do you make sure that that everybody agrees that this is a good and eligible patient for the center, for the trial? Then how to organize a travel to a carbon ion center from across the world. Patient will need lodging, will need insurance. How do you get this information transfer and store the information across the world? Because you're transferring patient information, and patient information is extremely sensitive data. How do you review these contours? Again, like in a timely manner, that like somebody generates contours in Canal and in Italy, and how do I show it in a timely manner to the Japanese colleagues? Dose review, same. The plan is ready. Everybody needs to agree that this is a good dose distribution. And then Cipher would also have a scientific part, which is research part, which is collection of blood samples and analysis of what we've actually done to these patients, and then try to understand, like the biological effects of this high LET radiation. And then the annual output constancy check across every X-ray site and every carbon site that is opening the trial. That's also a non-trivial task. Okay, so now our challenges, and here's a spoiler alert. Warning, warning, warning. We did it. 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 We opened the trial. We activated the sites, and we were actually recruiting subjects. Okay, so now I told you everything. This is it. And this is also, of course, it's just, it was possible due to this incredible, international team that worked on it. So in the United States, Dr. Hak Choi, David Scher, Dr. Robert Timmerman, Dr. Steve Jiang, the physicist, Mike Story, the radiation biologist, Kajal Desai, she's our administrative vice president for radiation oncology, and myself. In NIRS, look at this team that worked with us. So that was Dr. Hirano, he's the president of NIRS and QST, Dr. Tsuji. I'm sure all of you guys know Dr. Tsuji is the father of carbon nanotherapy. I call him in Japan, or maybe in across the globe. Dr. Kamada, Dr. Shigeru Yamada, who I think he also gave a talk in this lecture series this week here, so you had the chance to meet him. Then Dr. Matsufuji, physicist, Naoya Saotome, physicist, Dr. Mizuno, physicist, and then Dr. Noda, also a physicist, and Dr. Furukawa, physicist. In Gunma, Dr. Tatsuya Ono, he also gave a presentation here, so you had the pleasure to meet him. In Italy, obviously, like Piero Fossati at that time was in Italy, so a huge, like support from him was, otherwise this would never be able to do. Sandro Rossi was the general manager of the CNAO facility. Mario Ciocca is a physicist, and Silvia Molinelli was also a physicist at CNAO. And of course, Dr. Roberto Orecchia, without him, this would never be able to do, who was the scientific director also in the CNAO. But at the same time, he was a boss at IEO, and Veronica Dell'Acqua, medical doctor, in IEO in Italy. So this is this incredible team, and many of these guys you guys had a chance to read, to hear about from in the series this week. So you guys are super lucky that all these guys were able to speak to you and give their opinions on stuff. Now we overcome all challenges. Here it is. We opened the trial and everything worked, and indeed, like you see all these check marks. Look, all the check marks are there, all are green. And I'll just spend a couple of minutes here to actually tell you like how we did this. So first of all, where was the funding from? Answer, Toshiba, that's the vendor. So it was Toshiba that fully sponsored all the expenditures of this clinical trial. The credentialing of the sites has been finished, and all the sites, that were credentialed, we went through rigorously every single step, that we put into the protocol regarding the credentialing, as I mentioned a minute ago, and the credentialing letters have been issued. There you go. IRBs, institutional review boards, they approved the protocol in 3 different continents. That alone, is like a heroic effort, as I mentioned, because each institution, they have their scientific and institutional review boards. They scrutinized the protocol. They read every single line. We went back and forth, answered a million of questions, and voila, they approved it. They said it's safe. This is, like a good thing to do, and we got the stamps, and we proceeded. The biological modeling in 3 continents, was also overcome. So MKM versus LEM biological dose factors have been established. So Dr. Fossati with the Japanese colleagues, he wrote a beautiful paper with Silvia Molinelli, where they actually did this awesome comparison of a physical dose delivered in Japan and the same physical dose delivered in Italy. How is that perceived? The biological model that tells that answers what is the corresponding biological equivalent, to this physical dose was established. We knew what the factor difference was, and therefore we established this communication between when a treatment plan with the dose distribution was generated in CNAO. If you show that in Japan, those guys would say, I'm sorry, I don't understand, what this is. But if you translate that, with this conversions, that Dr. Fossati set up, at that moment, the Japanese guys, oh, now I understand. Okay, this makes sense. Or they would say, no, this is too hot or too cold. So that this was a very, very crucial factor, to actually make sense and to generate right? So both continents can actually talk about the dose distribution that we would be showing them. So this was super important. And then we worked out a deal with the company with the research. At that time, the physical dose distribution was there, but only one biological model was existing. And then we worked it out, and then we put in both biological models. So there was a simpler way to recalculate from one to another one. Randomization. All sites agreed that UTSW will randomize. And in other words, they tell us there's a patient, we flip the coin, we do the randomization. So we took this headache out of the carbon sites. Eligibility review, we established a fast communication between Japan, Italy, and United States. And we developed, the timing thresholds, in the sense like the information was sent within this and this time, we better respond because the patient is waiting to be enrolled. So that was solved. The travel to the Carbon Ion Center was of course, a big hurdle, but we hired a medical travel agency. We contracted it out, and we wrote the contract. And in that contract was very, very clearly specified what they're responsible for. They would pick up the patient at Tokyo Airport. For example, it's a patient flying from United States. So patient would be picked up at the Tokyo Airport, and then the medical travel agency would accompany this patient for the whole time, while this carbon ion therapy is happening in Japan. The lodging, the trial funded all the expenditures for a patient and one accompanying person. So that's important. That's not only the patient travels, but they're traveling pairs. So somebody who's a caregiver or somebody who takes care of that patient. So two people. Apartments would be rented in the vicinity of NIRS for 4 weeks, because the irradiation would be 1 week for sim, and then treatment planning, and then 3 weeks of delivery, because this is a 12 fraction delivery. Insurance, the travel agency did the insurance for the travel insurance, and then the trial resources including the carbon ion site was picking up the unexpected complications and hospitalizations in Chiba. So that was also solved. Information transfer and storage, we figure out how to do a HIPAA, in other words, a Health Protected Information Act compliant transfer, between the whole world. And there's a software called RedCap that would be actually collecting all that information. That will be our ground truth for all the patients, that were treated on the protocol. Contours review, again, we generated an international timelines that we agreed upon, like when the contours are done, when they need to be done, within which time, the Japanese colleagues, need to review it, and so when the Italians need to review it. Everybody agreed on it, so we had this very clear thresholds and the mechanism how to do this. Same for the dose review. Biological samples would have been collected. The trial also paid for collecting collecting these samples, freezing them down, actually processing them, freezing them down, and then shipping them back to UT Southwestern for the long-term collection and for the analysis. And the annual irradiation output constancy check has been done. There was one ion chamber, one electrometer, calibrated according to the standards of National Institutes of Standards and Technology in the United States, that traveled all over the world. It went to Japan. We delivered an end-to-end test, and we measured the dose. Traveled to CNAO, to Italy, did the same. And then within the United States, it's the IROC system that was insured for the output constancy. Okay, so we activated participating sites, and we opened the trial for recruitment, and we were recruiting subjects. This is it. Well, spoiler alert, spoiler alert, spoiler alert. Boom, this happened. 2020, coronavirus, travel bans, and it killed Cipher. Well, maybe only hibernated it, but at this moment, it looks like it killed it. So you guys remember all that work that was done above? This coronavirus did not do us a good favor. So in summary, the world's first phase 3 randomized international clinical trial comparing carbon ion therapy with photons, IMRT, was generated. was opened, was activated, and was actually recruiting patients. And COVID-19 killed the trial. Well, times have changed. Perhaps it was only a hibernation. I don't know. Maybe it can be resurrected. Maybe it's a wishful thinking. But I thank you very much for listening to me. And that was my last slide.
Thank you, Professor, for such a great talk on the Cipher trial. I am not seeing any questions on the Google Sheet. Are there any questions in the chat? No raised hands, but we are slightly late by 2 minutes, but maybe I'll splash a little bit into the coffee break with the permission of Professor Roach. What do you think it will take to resurrect Cipher? Because obviously everybody is with his eyes open to get real hard evidence and to, you know, throw it into the faces of the insurance companies and the public coffers that pay for cancer treatments.
Yes, I think, you know, what would take is our jumpstart, because you know, UT Southwestern, we're really on track of building a heavy ion center. So this was one of our, you know, like part of it, right? This is it, you know, like we're building this. And COVID not only killed this, but I only hope, you know, but it had a very bad ending for our, you know, like heavy ion building center, building the heavy ion center at UT Southwestern. So all this exists, the knowledge exists, and if UT Southwestern continues, you know, we hope, you know, try to build a heavy ion center, this should be resurrected. Or, you know, if some other colleagues, you know, in the United States, you know, just like, you know, Dr. Hoppy is all the time, you know, in contact with us and, you know, like working with us to discuss, you know, what would it take, you know, to make this center to continue with this trial. So in other words, it's funding, but I think, you know, the funding motivation still exists because this needs to be done, because it should open well, we'll discuss that in the plenary, in the panel discussion later. So in other words, in conclusion, I think, you know, we're here, the expertise is here, we've done it, and we just need to find a partner who is interested in, and we can, I hope, you know, we can get out of hibernation.
Thank you so much, Professor Pompos, for that really great talk. Very much appreciated, and we look forward to the round table with you later on.